Bismillahirrahmanirrahim. Good morning, everyone. Today's topic is going to be drugs used for infertility. So as you can see, we are really focusing on the anterior pituitary. We started with the growth hormone, prolactin, and then we moved to thyroid stimulating hormone, and now we're going to gonadotrophin releasing hormones. Okay, so we're going by sequence. Before I start, today's lecture is only concerned for female infertility. I'm not going to be talking about male infertility. And to be more specific, I'm going to be even focusing on not the part that has to do with surgery, with the need for surgical intervention, because this is a pharma lecture. So we're going to be talking about drugs that are there to stimulate ovulation. So this is the main focus, Ashan, to be clear. Okay, so when we say female infertility, in general, the figure for infertility in general, it's between 10 to 15% for couples, okay, which basically can be because of male issues or female issues. Now, this is a bit of a complicated model because this is a multifactorial. It's not one reason, okay? Now, the female part, which is mainly concerned with the ovulation, is 1/3. And so we use this hormonal therapy quite often. Okay, 1/3 is a big. Now, as you can see, we have female infertility, and underneath three main reasons why there might be female infertility. Either it could be because of the ovulation disorders. You can see that the size is bigger. It's the main cause. It's around 25%. Okay, in comparison to tumor abnormalities, and in this case, we have either can't do anything. There's no uterus. Someone was born with no uterus, can't do much. But maybe things that can be due to infections or obstructions or ectopic pregnancy where you need to do some surgical intervention. And that's not our topic for today. And endometriosis is the third reason for female infertility. Now, whenever, please keep it like a guide, we do not initiate medications or treatment if we don't do a thorough checkup. In other words, thyroid imbalance can lead to issues with infertility, and there could be other reasons. Okay, sometimes you need to do thorough physical examination. You need to do all the required tests and examinations prior to saying, okay, this is one issue and we can target it through hormonal administration. Okay, so we claim that the ovaries are the central organ in the female reproduction. Why? We assume. We say, guess what? Forget it all, it's the ovaries. Why? Why? Easy. First of all, it's the source of the ovules. It's where the ovules are hidden. And if we don't have ovules, there's no fertilization in the first place. What else? Hormones. Yes, the hormones. So they are also responsible to release certain hormones. So it really has a crucial role. And if we have a problem there, we have a big problem. Okay. So it's the host to the female gametes in both sides. And it has a crucial role in hormonal control of the menstrual cycle. And as you know that there's a trigger, we started saying that we are continuing with discussing the different hormones in the anterior pituitary. And as you know, that the anterior pituitary is controlled by the master, that is the hypothalamus. So if we're talking about ovulation, Okay, it starts from the hypothalamus, triggers the anterior pituitary. Ultimately, so the ultimate organ there is the ovaries. So it's basically the end organ, as clearly stated in the slide. It's the end organ of the hypothalamic pituitary ovarian axis. So here we are. If we have issues here, we have a big problem. Okay. Now, according to the WHO, they categorize female infertility into 3 groups. Okay, let's discuss. Group 1, it basically includes 10% of women. They can have a group 1 ovulation disorder that is hypogonadotrophic, hypogonadal, and ovulation. There's no ovulation. Sometimes it could be right from the beginning. Yani, a female, I know a female who was born and she reached 16 years of age, and there was no menstruation, no initiation of menstruation, there's nothing. And the issue was with the hypothalamus. So it's called primary hypothalamic or primary hypogonadotropic. Primary, yani, that's it. This was seen from the beginning. Secondary, and I believe it has another name, which is called functional anovulation. And this is seen with females who do really severe exercise and do not take care of their diet yet. Even females who are anorexic, they might have this secondary hypogonadotrophic anovulation. Okay. Now, the second group, okay, is basically includes a very large percentage, 85% of females, they are under this group. هن بيكونوا normal gonadotrophic, we can say, and they are what we call one of the cases اللي عندهم polycystic ovaries. Okay, polycystic ovulatory syndrome, people who have high levels of prolactin. Okay, these are called group 2. Group 2, and in this case, we need to address that clearly. Group 3, we call hypergonadotrophic. Levels of FSH and H, even GnRH, they're all high, but hypoestrogenic. Hypoestrogen, there's no release of estrogen. And this we can see لما يصير في عنا premature ovulation. There's no more, the reservoir of oocytes is vanished. Okay, this is group 3. And this includes a very small percentage, that is 5% of females have that under group 3. Okay, now we're going to talk about drugs under each group. So we will start with the treatments in general that will be discussed for today. Treatment for female infertility, gonadotropin therapies, and giving, just administering GnRH. Okay? And this we can assume that we give it for group 1, right? Clomiphene citrate, letrozole, follicle stimulating hormone, and these last 2, we're going to discuss them, which is some studies show that if you give certain drugs with the main track of medication, it can help what we call follicogenesis, okay? Some adjuvant therapy. It's debatable. Some studies show that there's no difference. Some studies show that there's some difference. We're gonna go across that. And novel drugs, and by saying by novel drugs, it's a novel finding, novel mutation. Okay, and that's the last one. Okay, so for group 1, as I said, remember we said that people who have secondary, we call them functional hypothalamic amenorrhea. Functional, yani, it's because something suddenly happened. as if the hypothalamic pituitary ovarian axis became dormant. And that dormancy did not start from the beginning, it starts later. So we did something to our body. We consumed its energy. We were not gentle with our bodies, that the hypothalamus decided to shut down. Okay? Now, obviously, we said we need to give gonadotropin releasing hormone. But the way we give it is very crucial. We give it so the old studies in the 70s and 80s, they showed that if we give it in an intermittent, yani we leave a gap, let's say 90 minutes, pulsatile manner, this is where we get a very good outcome. Okay, so we need to make sure we give these drugs in an intermittent, pulsatile manner. Okay, so again, I keep reminding in several slides that the prerequisite is we will have a thorough checkup, and we also need to make sure if I'm stimulating the hypothalamus, I need to make sure what is normal and working and functioning. What? Definitely the pituitary. If it's not working, then I'm doing nothing. I'm knocking the door and there's no one inside, right? Okay. So, as I said, the pulsatile intermittent administration of gonadotropin releasing hormone, the drug is called gonadotropin. And the way we give it, it's called Lutripulse. Lutripulse, the nice thing about it is that you don't need to worry. Just put it, sometimes it's given subcutaneous or intravenous, and the studies have shown subcutaneous has a better outcome. And again, it is effective in women with hypothalamic amenorrhea. Okay? Adverse effects, by the way, is very rare. However, they have to write it. Yani, when you look the gonadotropin, the pamphlet, and you read it, let me go ahead and just show you real quick here. If I go and enlarge it real here. Although we're talking about a very rare, less than 1% possibility of experiencing the hyperstimulation syndrome. Hyperstimulation syndrome, which is the other side of midnight. There's no stimulation, we give medication, and there is hyperstimulation. Hyperstimulation is basically, it's very painful. And in this case, it's very rare. And in this case, we need to stop the drug. Okay? Okay. The other warning that is really serious here, it's called serious warning precaution, and this is a mandatory label on the drug, it's the risk of cancer. And again, this is a very small number, it has been seen with a very small number, but I believe the FDA has just made it mandatory to have that label on. Okay, so let me take this back to its place here. Okay, and continue. So, first of all, risk of multiple folliculogenesis, yani multiple pregnancies. So that's a risk. If a woman is not ready to have 5 babies at a time, it's not good news for her, although she is infertile and she's eager to have a baby, but we call it risk. Okay, and the risk of hyperstimulation syndrome, where the ovaries, they swell, they become painful, and we don't like that. Okay, now group 2. In group 2, it's basically the disease under which group 2 is really stated. It's polycystic ovaries. Okay. And in polycystic ovaries, actually, if you want to understand the mechanism, it's a bit complicated, not very clear. Okay, but mainly there is some involvement of metabolic. Yani it's not only the hypothalamus pituitary ovarian axis; it's also the metabolic state of the body. Okay, so we have environmental factor that can lead, although there is some genetic factor, but to a higher extent, it's the environmental factor that are responsible for the PCOS. Okay. Now, what happens there? We have actually obese patients are more at risk of PCOS. It has been thought that we have high levels of androgens, and these hyper androgenic levels will lead to acne, will lead to hirsutism, and we have the inability to have proper ovulation. And في عندنا follicles, when you look under the ultrasound, you will see that this ovary is enlarged or the same size, but you will see it having these ovules enlarged and doesn't really look nice, but ovulation, it's not happening. And here, if you look again, we have as if the follicles that are inside the ovaries, they're arrested. They are arrested. So we have some follicular arrest and we have multiple immature follicles. So the reason is multifactorial, and because there is an involvement of the reproductive dysfunction and the metabolic disorders, so 2 in 1, insulin resistance is one of the reasons. That's why you will be surprised. How come I'm giving metformin to people with PCOS? And this is because it has been thought that metformin will improve the insulin resistance, and metformin, as you all know, improves the weight. Okay, and that's why we have now derivative of this drug for weight loss, and also improves the proper folliculogenesis, okay, and decreases the androgenic levels. That's when metformin is there. Okay, just you might ask, how come we are talking about gonads and fertility, and we have to treat with metformin? Okay. The other drug that has been really of higher efficacy than metformin is what we call clomiphene citrate. هلا clomiphene citrate is under the group of drugs بسموهم SERDs. SERDs اللي هن they are agonist antagonist groups, selective. So at certain areas they are agonist, estrogen agonist, but when the estrogen levels become so high, they are antagonists. Why would that help me? Because if we have high level of estrogen, this will go and create a negative feedback where? In both hypothalamus and pituitary. And as a result, there will be no more FSH and LH release, right? And we want ovulation to be strong. So at the level of the pituitary, the clomiphene citrate acts as an antagonist. So the estrogen is knocking at the door saying, open, stop, release, and no one is listening. Okay, and this is the mechanism of action of clomiphene citrate. Okay, now again, I need to put it in a PowerPoint mode. I'm sorry. Okay, so we give it for 5 days. We don't like to increase more than 6 cycles. Yani we repeat every cycle giving clomiphene. If pregnancy did not happen, but more than 6, it has been thought that it's not really recommended. Okay? No, yes. Mechanism. So you need ovulation, you need to stimulate the ovaries. And how you stimulate them? Through release of FSH and LH. Sometimes, if you have, first of all, in polycystic ovarian ovaries, we have higher even LH than FSH. So we stimulate the pituitary gland through blocking the negative feedback. That's all. Yes, blocks the negative feedback, and this is the way we release more. We keep on releasing more FSH and LH. Okay. Okay. And again, all these drugs, by the way, all of them, let's generalize. I think the exception if we use metformin for infertility, all of them, the risk of multiple pregnancies or multiple babies is there. Not excluded, never excluded. Okay? Okay. Okay, so We give it on day 2 of menstruation, 3, 4, or 5, and we continue for 5 days. And then the ovulation should occur 6 to 7 days later. Okay, ovulation rate is very high. However, pregnancy rate is less. Yani it's very interesting that we can monitor these patients. We see that they're ovulating, but the pregnancy is not happening in the same rate. And if I look, okay, 85% ovulation rate, I should expect 85% of pregnancy, but this is it's way less. Okay. Okay, now they have compared 2 drugs, and I'm going to introduce the second drug through this study. They introduced something, they compared a drug called clomiphene citrate, which we just discussed, with another drug called letrozole, and letrozole showed higher efficacy. So what is letrozole? Okay. Before I move on, as you can see here, they compared in terms of efficacy metformin and clomiphene, and I mentioned that the efficacy of clomiphene was higher, and the multiple pregnancies was seen with clomiphene, but was not seen with metformin. Okay, so it's written, but I mentioned it verbally. Okay, what is letrozole? Again, I missed one thing, and I apologize for that, which is there is the risk of ovarian hyperstimulation syndrome, the one we saw with gonadotropin-releasing hormone. It is there with also the clomiphene citrate. Why? Because of the dosing and because the risk that we are stimulating too much, and this might lead to the pain and enlargement of the ovaries. Okay. What is letrozole? Let's start with this. If I have, as you know, testosterone through certain enzymes called CYP19A, okay, another name for it is aromatase, turns the testosterone into estradiol, which is estrogen. Again, if I have too much estrogen, I will produce the negative feedback, which will stop the release of FSH and LH. And so in order for me to do it, I'm not going to do it through direct binding to the pituitary receptors. I will do it through stopping the production of more estrogen. And how? I block the enzyme. So this is called aromatase. Another name for CYP19A is aromatase. And we give something called aromatase inhibitors. Letrozole is an aromatase inhibitor. What does it do? It stops the conversion of, let's say, testosterone or androstenedione into the different forms of estrogen, either estradiol, which is more prevalent than estrone. Okay, with that, I am diminishing the amount, or decreasing the amount of estrogen levels in the body, which might in turn create that negative feedback in the hypothalamus and pituitary. And this is what we don't want. Okay, so aromatase is responsible for the aromatization. From aromatase, aromatic ring. So aromatase turns it into an aromatic ring. If you look at the structure of testosterone, just for you, when you memorize things, it's easier you know how. So aromatase turns the structure of testosterone into one of these rings into an aromatic ring. That's why we call it aromatase. Aromatase. So aromatase, another name for aromatase is what? CYP19A in this case. And we are giving something called letrozole, which is an aromatase inhibitor. Have you heard of aromatase inhibitors? Never? We never took any oncology, breast cancer. They give aromatase inhibitors. They give aromatase inhibitors for postmenopausal breast cancer patients. Okay? So, and you know why? We're decreasing the levels of estrogen. But they found that it can be used to induce ovulation by preventing estrogen negative feedback. Okay? Okay, now in terms of efficacy, if you look here, they found that the live birth, the percentage of live birth when giving letrozole was higher than clomiphene, and that's why they like to use letrozole. Okay, now we're done with clomiphene citrate, letrozole. gonadotropin releasing hormones. We're going to be talking about certain cases where we give LH or FSH. FSH mainly. Okay? Because if I give FSH, then I am triggering ovulation. So why can I give it externally? Makes sense. Yani when we look at the pathway, we say, okay, if I stimulate the hypothalamus, then this should work. When I stimulate the pituitary, then this also might work. And if I block the negative feedback, then this also should work, right? So they found out that giving LH and FSH, and sometimes they would give something called a human menopausal hormone, which is basically they extracted from the urine of postmenopausal women because these women have high FSH and LH, okay, which is the combo of both. So either you would give FSH alone or you would give them both. Okay. So follicle stimulating hormone, we have two sources, either highly purified urinary FSH, and now we know why. Where do we get them from? From postmenopausal women because of the high levels. We call it urofolitropin, or they synthesize it, family recombinant human FSH, اللي هي folitropin. In terms of efficacy, there's no difference. Either you would give it intramuscular or subcutaneous. Now, who do we give it to? Who do we give it to? Any patient who have failed clomiphene or letrozole, then our next option is giving FSH. Okay, either intramuscular or subcutaneous. Okay, and also for the process of IVF, we give these drugs. Now, adverse effects, local irritation at the injection site, multiple pregnancies. You feel bloated when you take these drugs. And definitely, whenever we talk about hormones, there's mood swings involved. The other drug, remember we said hyperprolactinemia. We mentioned that, you slept? No, the one, you slept? No, okay. So remember we said at the beginning when we discussed growth hormones and prolactin, and we said prolactin is linked with infertility. And how do we treat the hyperprolactinemia? We don't really have hypoprolactinemia. We rarely have hypoprolactinemia. So hyperprolactinemia, we treat it with what? Okay, so this is our next go-to medications. When do we give it? Of course, if we see with the blood results that we have high levels of prolactin, we can treat in parallel. We can treat clomiphene with bromocriptine. There's no issue. And this should reduce the production of prolactin. We have to avoid giving bromocriptine in patients with pituitary adenoma, because this is large adenomas, not small adenomas. The large adenomas, we need to avoid bromocriptine. Okay, we're done with the big material of today, alhamdulillah, and we're moving to what we call adjuvants. Now, when you look at the literature, you see that glucocorticoids, which was puzzling to me, Anna, because we say tremendous stress, severe stress can really harm us. But in certain cases, they would give prednisolone for patients to induce folliculogenesis. This has been clinically proven that giving glucocorticoids as adjuvant therapy, mainly with controlled ovarian hyperstimulation. Here, where I am in the process of doing IVF for these patients, I would give them these drugs beforehand, before I pick up the oocyte, our mature oocyte. Okay? Now, androgens. Androgens. This is very interesting because they found out this is mainly for, remember group 3? We said we have group 3, اللي هن hyper-gonadotrophic, hypoestrogenic. Yani we have high levels of SHLH, but because there's no reservoir of oocytes, then it's hypoestrogenic. Okay? And here they found that folliculogenesis would really improve if we add androgen. Why? Because it was thought that it will help, because it's mainly this is given for females who are need to have babies, but their age is quite high, يعني they're in 30s, 40s, okay? ايه؟ ايش؟ لا هم still young, don't worry, we're still young, بس احنا we have a fertile age, we have a peak fertile age. So once we يعني in terms of fertility, we're not saying the activity, we're not, it's low, okay? Okay, so giving testosterone increased the response of follicles to stimulation, especially in older women who are trying to conceive. Okay, last material اللي هن two things. Coenzyme Q10. Coenzyme Q10, it has been always as a supplement. People are talking about take coenzyme Q10 because it helps with your energy levels. And they find that if we are not able to have proper ovulation, something is wrong with our energy levels. So CoQ10 supplementation may improve human oocyte quality. And this has been seen in some papers, and I just took a picture of one of the papers because the link is the mitochondrial level. If we have optimal mitochondrial function, optimal ATP levels, this should reflect on the ability to have proper and mature ovules. Last material, okay, and we're early today, and it's a straightforward, not complicated, right, session, is a question that was triggered by so many scientists is what triggers human puberty? And seriously, we don't think about it. Do we? We don't think about it. What all of a sudden, why certain kids would get their puberty at 10 years? Now they're getting their puberty at 10 years. It's happening. Why people at 16? Why at 15? What happens? Okay, and so they're starting to look into the receptors that, if in certain diseases, is triggering the release of gonadotropin releasing hormone and starting this whole cycle, then maybe we should elaborate more in that field. So I'll give you an example. Something called kisspeptin and GPR54. GPR54 is a G protein coupled receptor. Okay, and they found that if it is mutated somehow, this whole trigger is dormant, as if we switch the light, no more. Okay, and so this is very important to do further studies on maybe create molecules that will modulate it, because that is one of the main pathways to trigger the hypothalamic pituitary axis. So in order to find novel modulators of gonadotropin releasing hormone secretion, genetic tools were employed in patients with, it's a rare disease, although it's called idiopathic hypogonadotrophic hypogonadism, but that tells us that there is a switch somewhere and other switches. We were able to find one, but there are other switches that in certain cases would be turned on. And what are the factors that would turn it on? And what are the factors that would turn it off? So this peptin molecule has been thought to trigger the release of gonadotropin releasing hormone and stimulate the whole pathway. And as a result, this will lead to proper ovulation. يعطيكم العافية.